Hi, my name is Genevieve Skinner, and I am the Advocacy Director for the Bleeding Disorders Foundation of North Carolina. And you will see my name peppered throughout this presentation as someone you can reach out to with any questions.
Hi, my name is Dr. Paulette Bryant, and I'm a pediatric hematologist, oncologist who loves hematology. And I started the first hemophilia treatment center in Charlotte, North Carolina. I'm retired now, but I work with the National Bleeding Disorder Foundation Board as their secretary. And I am here as your coach to understand this is something you can do for bleeding disorder patients and help their mental health.
I'm Dr. Matt Pace. I'm a licensed marriage and family therapist here in North Carolina, and I also have a teenage son with moderate hemophilia.
Hi, I'm Jillian Schultz. I am the parent of a 14-year-old boy who has hemophilia and who also has some mental health issues that we've been dealing with throughout his entire life. And you'll hear more about our story later on today. But wanted to just share our experiences so that others don't have to go through the same things that we have.
I'm Melissa Cruz. I'm a nurse practitioner and I work at Cherry Hospital in Goldsboro, North Carolina, which is one of three state psychiatric inpatient facilities. I also have a 6-year-old son with severe hemophilia, and we're going to give you some more information today about hemophilia and mental health facilities.
Hi, I'm Kate Baczynski. I'm the chair of the National Bleeding Disorder Substance Use and Mental Health Access Coalition, and I'm also the mother of a child, an 8-year-old son with severe hemophilia A.
Hi, everyone. My name is Kayla Cody Lushosi. I am the advocacy coordinator with BD SUMHAC. I'm also a social worker with background in behavioral health as well as HIV/AIDS care and treatment.
Hi, we are the Bleeding Disorders Substance Use, Mental Health, and Access Coalition, and we're here today to talk a little bit about the ways that we've discovered people with bleeding disorders are struggling to receive equitable access to care and ways that we know it can happen. So with that, I'll pass it over to Dr. Bryant.
Hello. First of all, I just want to thank BD SUMHAC for allowing us this space to talk about this very important issue and to be part of the solution. Let's get to the very beginning. What is a bleeding disorder? Where bleeding disorders are rare, genetic, lifelong conditions. You're missing a component in the blood that enables your blood to clot normally. Therefore, you bleed longer. There's no cure, but treatments are very effective, and we have so many new and upcoming technologies now that makes having hemophilia not as burdensome as what you might have seen a long time ago. Patients who have hemophilia or a bleeding disorder follow a treatment plan, meaning they get factor or the substance that they're missing in their blood or some other substance that helps them to bypass that missing step so that they don't bleed. Also, if they're not on preventative or prophylaxis treatment, they can treat themselves if they have a bleed or have trauma. So either way, they are able to live full lives, have average life expectancy as someone who doesn't have a bleeding disorder. They're healthy. And usually the only restrictions are we avoid high contact sports such as football and hockey and boxing. So this is really great. And treatments are primarily infusions or injections. Next slide. So you're probably thinking, well, an infusion or injection, that doesn't sound great. Actually, this is easy peasy, and we got this. It's a very small amount of factor that you get. It's in a bottle with directions of how to mix it. And then you get a needle that looks like a butterfly. How cool is that? It has 2 plastic edges on the side to help you guide in the needle. There's no IV poles, no hanging bags, no pumps, no nurses, no doctors, just people who know how to infuse. There's no oversight. And the picture on the other side, there's a little guy learning how to infuse. And you might say, wow, he's pretty young. We start training at 6 years of age. The kids go to camp, and usually other kids train them how to give their factor. It can take 5 to 10 minutes at most. And some sub-Q injections that you have for a bleeding disorder are less than 5 minutes, and they can last even a month. So this allows the person with the bleeding disorder to have a fulfilling life. Next slide. Your next question may be then, why are you talking to people who major in treating folks with mental disorders or substance use disorders? Well, because our bleeding community, as anybody with a chronic disease, needs access to these high quality services. Up to 58% of people with bleeding disorders report significant symptoms of anxiety, and the number is higher for depression. People also can have pain management issues. If you have a bleeding disorder and you bleed in your joint, you'll often have chronic pain. A lot of times we don't use NSAIDs for that because that can make the bleeding last a little bit longer. So that leaves us with opioids or narcotics. If you're having chronic pain, you can end up dependent on those for no fault of your own. That's why it's important for these patients to get their products, their factor on time, to have lifestyle changes to avoid bleeds. So they're not in this conundrum, but it can happen. If people don't get the mental health treatment they need or the treatment for their substance abuse, it can be disastrous or fatal. Next slide.
So you might be wondering, who is BD SUMHAC and what is our mission? Our mission is to advocate for access to appropriate substance use and mental health treatment facilities for all individuals with bleeding disorders, with a focus on inpatient and residential facilities. The focus is on inpatient and residential treatment because that is where we've seen most barriers to access. The community, fortunately, has not had difficulty accessing outpatient care. BD SUMHAC is a multi-stakeholder coalition that includes representatives from the National Bleeding Disorder Foundation, the Hemophilia Federation of America, Hemophilia Treatment Center providers, local chapters, and community members like myself. BD SUMHAC is not a mental health or substance use disorder treatment organization and does not offer behavioral health treatment or recommendations, but we advocate for the community and support providers in getting people with bleeding disorders the access that they need. Next slide, please. Of course, we can't tell the story of BD SUMHAC without telling the story of Derek, and his story is one that is sad and tragic, yet has inspired the creation of this coalition. Back in 2021, a young man named Derek, who had severe hemophilia and had a history of mental health and substance use issues, asked his HTC, his treatment center, for help finding a residential treatment facility for his substance use disorder. And although the treatment center, the nurse called many residential substance use disorder facilities, none of them would take a person with a bleeding disorder, especially one who required IV infusion medication. And sadly, without access to appropriate treatment, Derek overdosed and he died. He was only 20 years old. So, of course, Derek's death shocked the community and BD SUMHAC was born. And one of the first things we wanted to know was whether Derek's death was tragic but unusual, or whether or not others were also facing the same issue. Next slide, please. So, based on that, BD SUMHAC conducted a survey of all the HTCs nationwide and found that 83% of HTC providers who had attempted to refer a patient with a bleeding disorder to an inpatient or residential mental health or substance use treatment facility had received a denial. This was true for both adult and pediatric providers, as well as mental health and substance use treatment facilities. So clearly, this was and is a national problem.
This is, excuse me. So this is a picture of my son, and in this picture, he's about 10 or 11 years old. In 2020, he faced a barrier to inpatient mental health care. My son has hemophilia and has been managing mental health care issues since he was very young. And in 2020, things got pretty bad. And we had to call the crisis line multiple times. And eventually, on the third time we called, we said, enough is enough. He really needs treatment beyond what we have been able to provide him. And he needs to go to the hospital. So he was taken to the hospital where they agreed he needed inpatient mental health care. And the hospital where he was taken, he was placed on a special floor where all the children who were awaiting placement in a mental health care facility went to stay. There was no actual psychiatric care provided in that hospital. And he sat there. We met with a psychiatrist on a cart for about 10 minutes, maybe every day, and they agreed he needed mental health treatment and they put out a bed search. And after a couple of days, we were told they had found a bed. But then they came back to us and said, while we did find a bed, ultimately he cannot be admitted because he has hemophilia. And my husband and I really couldn't understand this. He was clearly in need of the treatment. The doctors believed he was needing the treatment, but they said he couldn't get it. And we asked why, and we were given a number of different reasons. We were told that they didn't take patients with diabetes, so why in the world would they take a patient who has hemophilia? They said, well, what if he got in a fight? And our response was, well, you do the same thing as any kid who has gotten into a fight. You treat them and they are managed and you move on. We were told that they were afraid what would happen if he needed to be restrained. We said, well, then you restrain him. While he was in that hospital waiting, we were also able to give him his treatment. My husband and I both infused his factor. He was giving himself factor probably about 50% of the time at that point, but we were able to bring it in and infuse it for him. But that was just not going to be an option. So next slide, please. So in the survey that we did, we found there were a number of reasons why patients with bleeding disorders were being denied access. We interviewed the providers who responded and found that the reasons fell into these different categories: infusions, needles, medical complexity, insurance issues, and access to factor. So the first reason had to do with IV infusions. Facilities said they didn't need to take anybody who received an IV medication. Second was the use of needles. So even people with injectable medications have had a hard time accessing care because facilities don't want people bringing in needles. So it could be a butterfly needle, it could be just an injection. We've heard anecdotally from the diabetes community that they've also faced issues. And like I said, that was one of the reasons that we had been told. We've also found that even in patients who don't use IV medication, so such as people who have mild hemophilia or von Willebrand disease, they're still getting denied because a facility fears what it would take to treat a person with a bleeding disorder. So even for people who are stable, facilities are afraid that they're too medically complex. Some of this, we believe, has to do with the fact that facilities have such long waiting lists that they cherry pick people and just deny people who sound like they're too complicated, which leaves our community without access. Additionally, as we've seen in other settings like skilled nursing facilities, we have seen some issues with insurance and access to factor. But right now, our focus is on getting people in the door because most are being denied even before they get to that point. As we deal with the first few issues, we anticipate seeing more issues to access in the future. I did want to add one additional thing. So the first situation happened in 2020. About 4 months ago, my son was in a similar situation and needed inpatient treatment again. And we had him go to a different hospital. This time it was a psychiatric emergency room. And they put out a bed search. And we had asked specifically about getting his infusion while he was there. And initially, they said it was fine, not a problem. And they just told us we had to bring in the medication, let them know how it worked. They would send it to their pharmacy and he would get his infusion. The next day, we brought in his medication while he was still waiting. They still had the bed search underway, not a problem. But then we received a phone call that night from the doctor who was concerned about my son giving him his infusion. They asked if I would be comfortable coming in to do the infusion, and I said that was totally fine. I wanted to get him his treatment that he needed. However, the day that he was due for his infusion, he suddenly no longer needed to have to be admitted into an inpatient facility. I did bring up accommodations regarding Section 504, and they said that only applies in a school setting. But as we'll talk about later on in this presentation, providing accommodations are fairly easy for patients with bleeding disorders. So it's still, an ongoing issue even since 2020. Next slide, please.
So what do the experts say about bleeding disorders and mental health and substance use disorders? Well, MASAC is the medical and scientific committee of the Bleeding Disorder Foundation. It's a national committee with some representatives from Canada and Europe, and they look at guidelines that help keep the bleeding disorder community safe. And this is what they said. Provided a person with a bleeding disorder is medically stable and can maintain their established treatment protocol, that's either the preventive factor or the factor when you have a bleed or whatever product you're on, having a bleeding disorder should not preclude a person from receiving mental health or substance use disorder treatment in a residential inpatient setting. So what that means is having a bleeding disorder and a mental health emergency should not preclude you from getting the care that you need, that Jillian eloquently talked about her son. Even recently, in November, MASAC updated their guidelines about what does medically stable mean. Medically stable means you have a program that you're either getting preventive factor or preventive medicine, or you're treating appropriately so that you're able to continue your everyday life. And that's what most of our patients are on. Some patients rarely get a bleed, so that if they should have a bleed, we're there as their hemophilia treatment center to go about treatment. It also goes through how to get the factor to the patient. Will the parents do it? Will a nursing service do it? Can someone on the staff do it? What are the rules and what training do they need? And in MASAC, I think it's 289, excuse me, the MASAC document that you can Google and go to the National Bleeding Disorder Foundation website. Look at that. It's very detailed. It goes in, what if the patient needs physical restraints or hold or emergency injections? There is nothing preventing them from getting the psychiatric or the substance use treatment they need emergently. But then it tells what to do in the back end. Someone with a bleeding disorder who gets an IM injection may need factor if they haven't been on preventive treatment before. Also, some medicines may make you bleed a little bit more than other medicines. That's what the Hemophilia Treatment Center is for. Electroconvulsive therapy has proven to be safe. There's two articles of folks who've had bleeding disorders who received it, but your bleeding disorder team may decide, oh, and most likely that you may need treatment before you receive those. And then what do you do with the patient who says, I don't want anything, I don't want to have my infusion today? We have long-acting products that might be a benefit, and some other products that might mitigate. I am a physician in Charlotte, and I was part of one of the first bleeding disorder hemophilia treatment centers in Charlotte. All of these things are doable. The staff is available 24/7 to help you get through this. Next slide. So if all you remember about my presentation, I hope you remember that, one, bleeding disorder patients do need mental health and substance use help. Two, this is not hard to do. This is easy peasy. And three, this slide, which is all of your resources. There are 5 North Carolina HTCs that you can call. They have someone on call 24/7. And you can call the Bleeding Disorder Foundation and contact Genevieve Skinner or send an email. And if possible, also think about assigning someone in your crew to be an advocate for someone with bleeding disorders, so you can get all this information together in one place. And if you have a patient that needs emergent services, you can access this information and get them what they need. Next slide.
So, national substance use disorder experts have weighed in to say what a well-managed bleeding disorder should not prevent a person from getting access to the substance use treatment that they need. In the 3rd edition of the ASAM criteria, there was language that suggested if a patient used IV medications, they should be placed in a level 4 facility or a hospital-based facility. But the 4th edition that was released in October of 2023 clarified this issue so that the use of infusion medication should not limit a person to hospital-based facilities. It clarifies that assuming a person's comorbid condition can be managed effectively, as most people with bleeding disorders can, then a person should be treated in the setting that is appropriate for their substance use issue or the other chronic condition, and the other chronic condition should not be a barrier. Next slide, please. Additionally, in May 2024, the federal government issued a clarification of Section 504. This is the federal policy that prohibits discrimination on the basis of disability. It clarified that, among other things, Section 504 applies to medical settings, not just educational settings. It also clarified that a facility cannot deny someone access on the basis of a diagnosis like a bleeding disorder. Instead, what the facility should do is conduct an individualized assessment into that person's needs and then make a determination as to whether or not the facility can accommodate those needs. We are excited about this new ruling because we believe that most of the time, once a facility talks with the person's bleeding disorders treatment team, they will realize that a bleeding disorder is actually very easily managed and should not be a barrier to accessing treatment. Next slide, please. And further, federal law requires behavioral health facilities to make reasonable accommodations to ensure access to their facilities for people with disabilities. Under this law, a bleeding disorder is considered a disability. Failure to make these reasonable accommodations is considered discrimination under the ADA.
So we have heard what a bleeding disorder looks like. We have heard what treatment usually looks like for people with bleeding disorders. And we've seen the federal regulations that require facilities to accommodate them. Now, some of the examples of things that we can do that provide reasonable accommodations include access to their bleeding disorder medication, secure climate-controlled storage for medication and supplies. A lot of these medications need to be refrigerated, as well as many other medications. So facilities need to make that available. Time during the day to receive medications, which is common with all medications that patients receive during the day. Allowing them to administer or self-infuse the medication, or alternatively, identifying a provider to administer the medication and just allowing them to have a private space to be able to do that. Next slide. So I am a medical provider with a state psychiatric facility in North Carolina. And we have worked through BD SUMHAC with the North Carolina Department of Health and Human Services to review what is actually permitted in facilities in North Carolina. And the regulations are very clear, and we've made sure that we are understanding them correctly. So regulations do permit facility staff to infuse or inject medications that are not for behavioral health indications. We still want to care for people's medical conditions that are not directly related to their substance use or their mental health. Furthermore, the regulations permit facilities to work with external providers and allow licensed or trained but unlicensed individuals to administer these infusions. This is very common within the bleeding disorder community. Once we have a family that it is in a hemophilia treatment center, they will work very closely with the family and with relatives to make sure that they are able to administer at home. So they're not tied to a facility. So we have visiting nurses, the staff from the hemophilia treatment center, staff from specialty pharmacy, and as we heard from Jillian earlier, also the parents and the patients themselves. But the medications, including injections, shall be administered only by persons or by unlicensed persons trained by a registered nurse, which happens in the hemophilia treatment centers, and other legally qualified persons. So once those orders are given, they are able to do that per regulation in North Carolina. Next slide. Furthermore, they do permit self-administration of infusions and injections. So North Carolina regulations permit people to self-infuse and self-inject medications at substance use disorder and mental health facilities. They just need to have written authorization from the client's physician to permit self-administration. So again, this is where we provide individualized care and treatment planning to work with the providers at the facility to allow them to have the order for those individuals to self-administer. Next slide. North Carolina regulations permit individuals to bring medications from home. Outside medications are allowed if the following criteria are met. The medication was originally provided by a pharmacy, and the facility's pharmacy assists with review and verification of the medication's label. Again, just going over the regulations so that we are all aware that it is allowed, and regulation does provide for the exception so that these things can be treated in any facility, whether it be a group home setting or an inpatient private facility or a state facility. Next slide. Like I said, I work at Cherry Hospital, which is one of the 3 state psychiatric acute care facilities in North Carolina. I also provide the screening for all admissions into this facility. I review their medical care and determine whether or not our facility can accommodate their medical needs. We have had several referrals over the last several years for people with bleeding disorders. The first one that I can recall, we received the referral and administration initially said, oh, we are not going to be able to accommodate this person with a bleeding disorder. All of the risks that we've already talked about. What happens if we need to give them IM injections into their muscle injections? What happens if they have to be restrained? How do we get their medications? We don't have those medications on our formulary. But we were able to provide a look at that particular case, and we were able to sit down with our nursing staff, with our pharmacy staff, and with the medical staff and come up with a plan. And actually, what happened with all of that is we were able to rewrite our policies more specifically to allow for patients to be able to self-inject. This was an adolescent patient, had the orders that the patient could self-infuse with direct observation from our nurses, again, to help reduce anxiety and risk of self-injury with that procedure. Furthermore, we further clarified that we wanted to modify our policies for not just people with bleeding disorders, but also people on anticoagulation medication, which has some of the same risks as people not on preventative treatment with bleeding disorders. So we now have special accommodations for people getting injections with bleeding disorders and for when they're on anticoagulation medication. But just summarizing, being able to look at a patient individually, looking at what their treatment center, because we coordinated with this patient's hemophilia treatment center, what is the patient currently getting, what will best serve that patient so that we can provide the acute mental health treatment that they needed at that time and still accommodate all of their medical needs. It was something that was able to be done, and it was done in about half a day. And this is at a large state facility with lots of bureaucratic procedures that we had to go through. So it is doable. The patient did well, and we were able to actually place them in a group home after discharge from us. So we were able to downgrade them to another mental health treatment facility and allow them to continue on with their life. So it can work. It is doable. And it does not take a lot of effort, but it allows people to receive the treatment that they need. So again, we are a resource. We've provided a lot of the information for different places that you can go to contact people with BD SUMHAC or with the other bleeding disorder organizations to get assistance, and also always reach out to your hemophilia treatment centers. Next slide. So this is an image of one of the bleeding disorder community members who is at a hemophilia camp. And he is on a canoe. You do see that correctly. And he is giving himself his hemophilia medication. Again, these camps, a lot of times they do go and they learn how to self-infuse. They gain confidence in that. But we would like to show you guys this, because if you can infuse in a canoe, you can infuse anywhere. You can infuse in a medication room at a facility. You can infuse in the bedroom of a group home. There really is nothing that would preclude you from being able to get the medication that you need, and in that, get the mental health or substance use treatment that you need.
And I would just add quick to that. My son has been self-infusing since he was 8 years old. He learned at camp, and he saw another child do his infusion, and he said, I'm going to do this as well. So that's been something that has been part of his life since he was very young. So these opportunities really provide quite a lot of freedom for people with bleeding disorders. Next slide, please. So just to recap, this is a QR code. If you scan the QR code, it will take you to a survey, just so we can get some more information about experiences that facilities in North Carolina have had. If you can scan that QR code and take the survey, it would really help us with our advocacy efforts, and we would very much appreciate that. Next slide, please.
We want to thank you. Thanks to the facility staff for taking the time to watch and listen and learn about our community and this very important access issue. As Jillian shared, please use that link and share your feedback through that survey. Also, as you can see on this slide, as Dr. Bryant mentioned earlier, there are many resources available in North Carolina to support you in accepting individuals with bleeding disorders. There are the HTC resources, as well as the resources at the Bleeding Disorders Foundation of North Carolina. If you have any questions and follow up to this presentation, please do not hesitate to reach out to Genevieve, the advocacy director who you heard from before. Lots of people are ready to help with this. We welcome the opportunity to continue the conversation. Finally, I want to thank DHHS for giving us the opportunity to present to you today. We are truly grateful for your partnership and your support.